Welcome to a presentation from the Luke Waits Center for Dyslexia and Learning Disorders, located in Scottish Rite for Children's Dallas campus. Scottish Rite for Children is one of the nation's leading pediatric centers for the treatment of orthopedic conditions, certain related neurological and arthritic disorders, and through the Luke Waits Center, the organization also offers expertise in learning disorders, including dyslexia. Dr. Luke Waits, our founder, was a neurologist who was invited to join Scottish Rite in the mid-1960s. He supported the hospital's neurology needs and also continued his work of studying dyslexia and brought his existing dyslexia clinic along with him. Our center has been part of Scottish Rite since 1965. Our department provides a variety of services, including dyslexia training for students and teachers, research, outreach, and diagnostics. The Center for Dyslexia offers services when there will be a difference in the educational outcome of a child with academic problems. We also have the opportunity to address comorbid or coexisting mental health diagnoses, ADHD, anxiety, depression, etc., in the context of the evaluation, as long as the primary concern is academics. For more than 55 years, we have also been developing curricula and interventions to help children with dyslexia learn how to read. We implement the curricula and conduct research in an ongoing effort of continuously improving and adapting the program in order to provide the best options possible.
Hi, I'm Robert Kindell, a licensed psychologist and assessment specialist.
And I'm Guernisha Sanford, a licensed master social worker.
Here are the goals of today's presentation. Guernisha and I will attempt to narrow down the broad field of anxiety into smaller parts parents may find useful. Following the presentation, we hope each parent or guardian will have a better understanding of their child's anxiety and diagnosis if they have received one. We will also discuss the role of anxiety on school performance with a focus on test-taking anxiety. We will provide you with ideas of coping skills that can be used at home or in public places like school. And finally, we'd like to discuss anxiety across the lifespan. During the course of today's presentation, you may have questions or comments. Please feel free to email the link at the bottom of the slide. So what is anxiety? It is one of the most common mental health challenges in children. In fact, it is estimated that 1 out of every 5 children and teens demonstrate significant symptoms of anxiety at any given point. Anxiety contains 2 important components: psychological symptoms and physiological symptoms. First, let's discuss psychological symptoms, primarily fear and anxiety. Fear is an emotional response to a real or perceived imminent threat. The emphasis there is on the word imminent, so coming soon. When we think about fear, we tend to think more in terms of shorter duration. When we see a spider moving towards us, the feeling when we are watching a scary movie, or walking to our cars at night in a parking lot. Fear is related with more surges of arousal that is necessary for that fight or flight response. Anxiety is the anticipation of a future threat. It is more connected with muscle tension, cautious or avoidant behavior, and preparation for that future danger. For example, when you know ahead of time you have to perform in front of others, like when you're asked to do a presentation on anxiety that will live forever on YouTube. Physiological symptoms of anxiety are our body's response to stress. These may include feelings of restlessness or being tense, increased heart rate, heavy breathing or hyperventilating, sweating, trouble concentrating, trouble sleeping, or gastrointestinal distress or diarrhea. It is these physical symptoms that let you know you're having an anxious moment. These physical symptoms of anxiety may not be easily identifiable in our children. You may not be able to see someone's heart racing or know their palms are sweaty if you don't touch them. Thus, if someone is not showing obvious physical symptoms, this does not mean they aren't having significant symptoms of anxiety. We all have some level of anxiety. Thus, having anxiety is normal. In fact, having anxiety keeps us safe and can increase our ability to perform a task. But when does it become a problem? When the anxiety becomes excessive in either intensity or duration. For a child with normal anxiety, This anxiety may be manageable or may decrease when more pressing matters arise. So a child who is anxious on the first day of school but notices their younger sibling is anxious. The older child may now focus their energy on helping their own sibling, forgetting about their own anxious feelings. Normal anxiety is typically short in duration. It is normal to be anxious on the first day of school. We really don't know our teacher or the other children in our class, where we're going to sit or which bus to take home. We shouldn't demonstrate this anxiety 2 to 3 weeks into school. While a child may show some physical symptoms of anxiety, these symptoms are typically not significant. So now, when is it a disorder? Your symptoms of anxiety are stopping you from doing something or hindering your ability to demonstrate who you really are or what you know. So this may be the child whose anxiety is so high they can't participate in baseball despite showing up every week and their parent is one of the coaches. Symptoms are long in duration. Depending on the disorder, symptoms must persist anywhere from 1 month to 6 months. And there are physical symptoms of anxiety. These physical symptoms of anxiety have a circular relationship with psychological symptoms. Often when an individual is feeling or showing physical symptoms, they now become worried that their physical symptoms are obvious to others. Others now know they are anxious, which raises their level of psychological worry. So where does anxiety come from? This is the old nature versus nurture debate, but what research tells us is that it's both. Not to point fingers here, but a large portion of our anxiety symptoms come from our parents. The most obvious is our genetic material. When we pass down our genes, we're not just passing down our eye color. We are also passing down our predisposition to acquire, in this case, to acquire significant anxiety. It has been estimated that around 40 to 50% of a child's anxious symptomology can be attributed to their genetic differences. Parenting anxiety also plays an important role. We primarily learn how to navigate our environment, especially in the early years, from our parents. If our parents are anxious, we will pick up on those tendencies. Think about the parent being anxious about flying. Seeing the parent being anxious tells the child that the airplane and/or act of flying is probably not safe. One study found a high link between separation anxiety in children and persistent anxiety in mothers. In that study, the majority of children who met criteria for separation anxiety had mothers who had a history of lifelong anxiety. And more than half of those mothers currently met criteria for a significant anxiety disorder. Also, it has been shown that children with one or more anxious parents have less favorable outcomes in therapy when compared to children without anxious parents. Parenting styles that focus on overprotection, overcontrol, and reinforcement of avoidance have also been shown to be connected with high levels of childhood anxiety. They can pass on the message to the child that you are incapable of doing something on your own. These are more authoritarian or helicopter parenting styles. For children, their attachment style may be related with anxiety symptoms. Anxious resistant attachment style in infancy predicted symptoms of anxiety in late adolescence. In this form of attachment, the infant may appear anxious in the parent's presence, distressed in the parent's absence, and angry upon the parent's return, often resisting contact with the parent. And this is connected with elevated physiological arousal. This temperament style also has a strong genetic component. But it is also important to note that not all children with this temperament style have an anxious parent, nor are they guaranteed to develop an anxiety disorder. It simply increases the odds. Trauma has been connected with high levels of fear relating to a stimulus or stimulus associations. For example, there are almost always higher incidence rates of anxiety following a natural disaster. It is really important to note not all trauma has to be perceived as significant in the eyes of society. So trauma doesn't have to be a parent's death, natural disaster, or sexual abuse. Trauma could simply be a pet fish dying, which may lead to symptoms of anxiety. In this example, the death of the pet fish may elicit questions about parent mortality, and the child may display symptoms of separation anxiety. Not all children who experience trauma develop anxiety, and the initial anxiety following trauma typically dissipates. One strong predictive variable on if trauma turns into significant anxiety is parent behavior. The more anxious or overprotective a parent is following trauma, the higher levels of post-traumatic anxiety the child may exhibit. Some protective factors in preventing trauma are social support and already established coping skills. While there are many anxiety disorders, we are going to focus on the ones commonly seen in children. A specific phobia is a fear of something specific: spiders, needles, airplanes. With a specific phobia, we can either endure the stimulus with intense stress or actively avoid the stimulus. With something like spiders, we really can't avoid them. While we have to endure the stress, we can also take precautions to limit the exposure. We can call a pest control company or clean frequently. There are stimuli we can easily avoid, such as flying. If we fear flying, we simply don't fly. However, this does not mean we don't endure the stress of our anxiety. When we avoid a stimuli, it may cause functional impairment in other areas. If we don't fly, we have to drive. This takes a lot longer and can eat up days in our vacation. If we fear needles, we may have an increased risk of catching the flu because we didn't get a flu shot, or other medical issues because in our attempt to avoid needles, we may avoid doctors entirely. Thus, we may not catch another problem early. When you have a specific phobia, it doesn't have to be just one stimulus. In fact, approximately 75% of those with a specific phobia have more than one. The average individual with this disorder has 3. As opposed to some of the other anxiety disorders, specifically as we get to more generalized, this disorder is paired with more sympathetic nervous system, that immediate spike in heart rate and adrenaline to help us get out of danger. This disorder is also related with fainting or near fainting. In development, it doesn't have to, but this disorder usually develops early in childhood, typically prior to the age of 10. In childhood, these phobias tend to be related to natural events, animals, blood, injection, and injury. The phobias tend to have an ebb and flow during childhood and adolescence. While we see the definition of separation anxiety on the screen, in layman's terms, you have trouble separating from your caregiver, parent, or guardian. In this, you are typically worried about an event, losing this person, or harm to them. So you are worried about getting lost in a store, your parent's death, or your parents getting into a car accident. Symptoms have to last at least 4 weeks. Symptoms may be present as the need for constant attention. A child may be asking random questions during a parent's personal time, like using the restroom. There may be a refusal to leave home or a refusal to be alone, even within the comfort of their family's home. They may have nightmares about separation, and they may complain about physical symptoms in anticipation or during an event, so headaches or stomach aches. Now, here's one myth. We typically relate this disorder with the act of physically separating from the caregiver. So in that scenario, the child is leaving the parent's car in the morning to go to school, or the parent leaving to go to a store. However, the distress in the child can occur prior to an event or after an event has already happened. So they may be sitting in school wondering if their parent is okay. Right there, we see an example of how separation anxiety impacts learning. If they're so focused on anxious thoughts, they're not focused on learning. But the impact can also be seen in other areas. Socially, they may not want to go to a friend's house or may become socially withdrawn. They may have school refusal, which in turn leads to academic trouble and social difficulties. Or they may show a persistent level of sadness. This occurs generally at the same rate in males and females, but slightly more in females during school age. Separation in infancy is normal, but separation anxiety can develop after life stress. As mentioned previously, this stress doesn't have to be something what us adults would consider significant, a parent or grandparent death. This could be moving to a new school, hearing the news of a disaster, or another pet fish dying. In the course of separation anxiety, there are periods of increased and decreased symptoms. The majority of children with separation anxiety do not have an anxiety disorder in adulthood. With that said, there is a high relationship with a specific phobia or generalized anxiety disorder, which we'll talk about in a minute. Overall, social anxiety disorder is a fear which can be from having a conversation, performing in front of others, or simply being observed. The fear is they will act in a way that will be negatively judged. They worry that they will look weak, boring, unlikable, or worry that they will be humiliated or rejected. As mentioned earlier, the anxiety symptoms they demonstrate can in turn cause more anxiety. The child may fear their anxiety symptoms, trembling or sweating, are apparent to others. Now, this anxiety must occur in a peer setting and not just with adults. Social situations almost always elicit fear, and this fear is at a proportion with expectations for the situation. The child may be seen crying, freezing, not engaging, or not speaking. The child may be attempting to avoid social situations overall or enduring them with significant stress. No coincidence that social anxiety disorder is related with poor friendship quality, that is less supportive and less close. It can cause impairments in other areas. For example, adolescents with this disorder have a higher rate of school dropout. Approximately 75% of children with social anxiety disorder develop it between the ages of 8 and 15, with the median onset around age 13. This coincides with expansion of social interactions, such as dating, and emphasis on social hierarchy. This disorder can occur in childhood and may follow a stressful or event like being bullied. Selective mutism is the consistent failure to speak when expected to. It can occur in situations with children and/or adults. The child has appropriate language skills and may speak at home or in the presence of immediate family, but they may shut down in front of close friends or secondary family like grandparents. Symptoms may not stop them from engaging in an act. For example, a child with selective mutism may not have anxiety about going to a store with a family friend, but they won't speak to that individual. They tend to prefer nonverbal communication. Symptoms occur for at least 1 month, not limited to the first month of school. A child with selective mutism almost always meets criteria for another anxiety disorder, most commonly social anxiety disorder, but also separation anxiety and specific phobia. In most cases, where there is selective mutism and social anxiety disorder, the mutism fades, but social anxiety remains. It's related with high social anxiety, shyness, fear of embarrassment, isolation, and withdrawal. It may result in teasing from peers, as these children are easy targets because they won't talk back. It's also related with academic impairment. If you are refusing to speak in school, it's really hard for the teacher to assess your reading skills. It's somewhat rarer of an anxiety disorder, with some studies suggesting that it only occurs in 0.03% at any given moment. Research says that it may happen slightly more in females. While onset is usually before the age of 5, it becomes an area of significant concern when the child begins to enter school. Parents and teachers now express concern because the child is not engaging in the material or with their peers. Next, we will talk about generalized anxiety disorder, which is commonly referred to as GAD. In GAD, the child finds it very difficult to control the worry, and this worry occurs almost all days for a long period of time. Symptoms must be present for at least 6 months. This worry is at a proportion to the actual likelihood or impact of the event. For children, this worry tends to be about their competence or quality of their performance, even in sports. It may show up as worry related to being on time, worry related to a catastrophic event, or perfectionism. It can be related with restlessness, mental fatigue, trouble concentrating, irritability, muscle tension, and sleep disturbance. Children may also experience headaches, stomach aches, and diarrhea. In children, you only need to see one of these symptoms. GAD appears the opposite of a specific phobia in terms of physical symptoms. GAD appears the opposite of a specific phobia in terms of physical symptoms. With a specific phobia, you will see a significant spike in symptoms when the stimulus is present. With GAD, there is an elevated but much lower and constant level of physical symptoms. They appear more like someone who is under a high level of daily stress. Thus, symptoms like shortness of breath and fainting are much less commonly seen in GAD. With GAD, the worry may shift from one concern to another, but physical symptoms of anxiety in GAD tend to be chronic. Rates of full remission or someone fully overcoming this disorder are pretty low, so focus of treatment typically involves managing symptoms and decreasing the impact of the next wave of anxiety. Approximately 1% of adolescents experience GAD over the course of a year. Adolescent girls are twice as likely to be diagnosed with GAD than males. With that said, GAD is rarely identified prior to adolescence. In fact, the mean onset of GAD is age 35. But it is important to note that earlier in life generalized anxiety disorder is identified, it is related to more impairment and with other disorders like depression. GAD is commonly observed with academic difficulties, not because the child has a learning disorder, but because GAD impacts their ability to complete tasks like tests quickly and efficiently. In a child who is a perfectionist, they may redo tasks or reread comprehension questions or passages multiple times. They are either dissatisfied with their performance or they are afraid of making mistakes. Sometimes on tests, you will see a really big difference in the accuracy from the first portion to the second portion of a test. In the first portion, they are slow and rechecking their answers. In the second portion, they realize they are running out of time, feel pressured, and attempt to answer the items quickly as possible, often at the cost of accuracy. When we discuss test-taking anxiety, we are going to use this Haney model developed by Patricia Lowe and her colleagues. Inside the thermometer bulb, they define test-taking anxiety as a combination of psychological, physiological, and behavioral functions. For psychological, that's anxiety and cognitive disruption. Cognitive disruption is a degree to which your symptoms of anxiety negatively impact your ability to organize your thoughts, use your working memory, or concentrate on the task. This disruption can actually increase as the child takes the test. As they perceive themselves to perform poorly, the anxiety can increase, further impacting their performance. Physiological symptoms, as mentioned earlier, are rapid heart rate and sweating. The behavioral aspect, that's avoiding the task or procrastination and subsequent cramming. Students have different physiological and psychological responses depending on the intensity of the test. That is, with more high-stakes testing, think the STAR here in Texas, children will likely demonstrate more worry and physical symptoms compared to when they're completing a regular or class test. So using our bulb here on the side, it is quite possible that the child has symptoms of anxiety on a regular test that facilitates or improves their performance. However, as the anxiety increases on more high-stakes testing, their symptoms of anxiety become an obstacle in their ability to demonstrate their skills. This is one potential cause of the child who does really well throughout the school year but bombs the STAR. While there are many different ways anxiety can impact a student's performance, probably no domain has been studied more than the impact of anxiety on memory. Anxiety has been shown to be related with poor retention of information or long-term memory. This also appears to have a reciprocal relationship. As you are poorly retaining the information, your anxiety about your future performance is going to increase. One theory of how this occurs is that the anxiety impacts attention. If you're not attending, then you aren't processing or retaining the information. The student is so focused on performing poorly and not paying attention to what they are studying. Anxiety also impacts short-term working memory. This can impact our performance both studying for the test and during the test. Working memory is an important factor in tasks like reading comprehension. As you're moving from one word to the next, you are processing the information you just read and storing that information for future use. This is sometimes the reason we see children who are excellent readers but have trouble with reading comprehension, especially if they have to read out loud in front of others. Working memory is also connected with mathematics and written expression. So let's expand on that model by Lowe and her associates. What we see on the bottom right side is that there are two loops of how anxiety impacts academic performance. One directly to the right of the bulb and one below the bulb flowing to the left. The first one is the child's immediate appraisal of their test performance, or how well am I doing on this test? As we have discussed, this perception can increase and lower overall test performance. The second loop involves not only their actual score, but their perception of their performance and, more importantly, their perception of their skills and abilities. There is an association between a child's self-reported anxiety symptoms and their grades. Not surprisingly, the higher the anxiety, the lower the grades. This connection tends to become stronger as the child increases in grade, encountering more high-stakes testing. The primary goal of test-taking anxiety intervention is to reduce the perceived threat of the test. Thus, we'd want to tackle the aspects in the yellow box. Interventions may include therapy to change behavior and cognition, developing better study skills and habits, developing better test-taking skills, and increasing their perception of their performance. Biofeedback has also been shown to reduce test-taking anxieties when paired with relaxation techniques. In this, the student is taught to calm themselves and reduce their heart rate, which reduces the negative impact of their anxiety on performance. Therefore, their grades improve. While therapy can assist with behaviors and cognitions, I often recommend working with an educational therapist. This is not quite a tutor, but someone who can take your child's educational profile and diagnosis and build specific study and test-taking strategies for them. Now that we have finished defining anxiety and discussing its role on school performance, I'm going to pass the mic to Garnisha. She'll talk about how to have a conversation with your child about anxiety and the coping strategies you can use at home and in school.
Thank you, Robert. Now let's talk about helping your child understand anxiety. When explaining anxiety, remember to keep it simple and use everyday language and words that they will understand. So, younger children may understand anxiety as being nervous or worried, and older children may understand the exact words, but can also understand the terms anxious and anxiety. Next, you want to help your child understand the components of anxiety. So earlier, we learned that it could show up in different ways, and helping your child understand the components can help them label and recognize this. Anxiety can show up in thoughts, such as, what if mom doesn't come home? It can show up in physical feelings. That can be stomach ache, headache, heart racing, sweaty palms, and other physical symptoms. It can show up in their behavior, going to find mom, staying home from school, having trouble separating, or even acting out. Once they have this understanding, it's necessary to explain the purpose of anxiety. And this is normal and okay. We know that anxiety can help activate and prepare us for danger, such as a bear confronting you in the woods, or for performing at your best, like a test or giving a presentation on anxiety. But anxiety can become a problem when it tells our brain to react as if there is danger in the absence of it. For an example, we know that a smoke alarm protects us from fire, but sometimes a smoke alarm can go off when there is no fire, like burning food, and if the smoke alarm goes off when there is no real danger, we may need to fix it. A way to help them understand is by talking to them, to help them open up about their worries and fears. Ways to engage in dialogue can be done by asking open-ended questions such as, can you tell me about a time when you felt nervous or scared? What did it feel like? What are some things that make you feel worried? You can always share examples of what makes you anxious. You can say, when I was your age, I was scared of blank, or recently I was worried about blank. Remember, when given an example, to be thoughtful of that example that you use. Previously, we learned that parents can contribute to their child being worried. So I would not use an example of being worried about getting in a car wreck when driving or anything like that. So you may want to practice that example. Another thing is to validate their feeling with no judgment and active listening. You don't want to dismiss their fears by saying, it's okay, don't worry, don't think about it. To them, their worry is real and can be significant to them. If your child does not want to talk, that is okay. You can continue to encourage openness by letting them know that you are open to listen to them anytime they are ready and that you really care and love them. Once your child understands the term anxiety, there are things that you can do at home along with supporting them, and that's coping skills. Sometimes it can be hard for kids to explain their feelings or talk about the racing thoughts in their head. Having them write in a journal, draw, or color can be helpful. For instance, I had a student who had a hard time walking into his classroom, but could not explain the reason why. So we drew an outline of a body, and the student was able to color and show me where he was feeling anxious, and that was in his stomach and feet. Knowing this information helped me find ways to help him overcome this fear. Next is a coping skill box, and this is really neat because it's mobile. So this box your child can help make because it's important they feel connected and understand the items in there that can help calm them when they're feeling anxious. So your child should know and like what's inside. You may also want to be mindful if you decide to put in electronics because this can do the opposite and become a fun thing for them. A way to use this box is if your child gets anxious on a long road trip or plane ride, and this is something that they can take with them. Now we have meditation. This can be a small place at home for your child to go to, help them relax or gather their thoughts. It helps them focus on their emotions and find ways to express them in a controlled and healthy way. Or you can create a relaxing spot that is a safe space for them to go to when they are anxious to help them relax or gather their thoughts. Please remember that you don't want to use the same spot that you use for timeout. Taking a walk or listening to music. This can help your child regulate emotions and release their brain and body from stress. And letting your child know that asking for help is okay. They can talk to you or a family member. If it's hard for them to talk, you can just have them write a note to you or something like that. Now that you have some skills at home, let's go over some coping skills that your child can use in public. I'm sure we all know about deep breathing and how it's helpful to slowly breathe through your nose and out your mouth. An easy way for your child to remember to take a deep breath is to think of a box. They will inhale, holding for 4 seconds, and exhale slowly for 4 seconds. If they need a visual to help them at school or in public, they can look at the ceiling, a window, just from going to corner, or even use a piece of paper or desk. There is also grounding techniques, and this helps focus on things around them rather than on the thoughts and feelings that are distressing them by using their 5 senses. 5 things you can see: a chair, a desk, a teacher, the sun. 4 things you can feel: your feet on the floor, your toes, the desk. 3 things you can hear: teachers, peers, clock ticking. 2 things you can smell: perfume, food. You can also put lavender on your kiddo's wrist before a test and they can smell that. 1 thing you can taste: breakfast, toothpaste. Now, I will say sometimes with grounding, it can be hard to remember, so you can practice this with your child or have them start off slowly with 1 thing and slowly adding it. Now, I will say with grounding, it can be hard to remember, so you can practice or have your child start from 1 thing and slowly adding. Next is help from a teacher. Parents, it's okay to talk to the teacher and come up with a plan that works for your child. So if your kiddo gets anxious at school during a test, reading out loud, during presentations, you may want them to be aware and for your child to know that they are there to help. So maybe creating a signal to the teacher by placing a highlighter on the desk. This could let the teacher know that they need a water break or start to feel anxious. If they need a break to cool their bodies, the teacher should monitor them. But again, working with the teacher and letting them know what is going on is important. The next thing we have is 5-finger breathing. This technique, you want to use the pointer finger of your other hand and trace around the outline of your hand and fingers. Breathe out as you slide down and breathe in as you slide your finger up. So let's give it a try. Take your right hand and spread your fingers. Use your left pointer finger and trace the outline of your hand. When you go up, you're going to breathe in. When you slide down, you're going to breathe out. So let's try it again. You slide up, breathe in, slide down, breathe out. You're going to continue to do this, and you're going to show this to your child, how easy it is to breathe in, to breathe out. Breathe in and breathe out. At the end, you can ask your child, how do they feel? Are they calm? And if they need to take another 5 breaths. There's also mobile apps for kids. For younger children, they have Breathe, Think, Do with Sesame Street. This is a bilingual app that can help your child learn skills such as problem solving, deep breathing, self-control, and planning. Your child will help a monster friend take deep breaths and think of plans and try them out. There's also Dreamy Kid. This app provides meditation, affirmation, healing activities, sleep stories, and more. For older kids, you have Headspace, Calm, Stop, Breathe, and Think, the mindfulness app, My Calm Beat. My Calm Beat apps helps them control their breathing, and there's many more out there. One question many parents ask, when to consider therapy? Not every kid with anxiety needs to see a counselor. Sometimes the child just needs a little extra support from mom or dad, learning coping skills at home, at school, and a conversation about anxiety. Again, anxiety is normal. So let's go over some common worries. Age 2 to 4 years old, fear of the dark, the potty, shadows, being separated from a parent, weather, loud noises. Ages 5 to 7 years old, fear of dark, bad guys, fire, peer rejection, doctors or shots, bugs and animals, taking a test. Age 8 to 14 years old, fear of dying, being home alone, sickness, bad guys, ghosts, school failure, throwing up at school, peer rejection. Age 12 to 16 years old, fear of death, peer rejection, school, sports performance, global issues, how they look to others, failure. Age 17 to 20, fear of health germs, death, being an adult, romantic rejections, dating, being homeless, responsibilities. So it would be best if you consider therapy if your child needs a space to talk freely and voice their worries and thoughts. Sometimes they may feel more comfortable talking to someone outside their family. Therapy is good when the anxiety is overactive and no longer typical. When it starts to cause problems in their daily function, like going to school, separating from parents, issues at school, or making friends, when this becomes a problem, therapy may need to be considered. There are different types of therapy for anxiety. Cognitive behavior therapy can help them recognize useful thoughts and behaviors and learn how to change them. It can help your child understand the negativity of their thought pattern and learn how to replace them with more positive one. Play pediatric talk therapy. Play therapy is a form of therapy that is used primarily for children because children may not be able to process their own emotions or articulate problems to parents or other adults. Through play, children can learn new coping mechanisms and how to redirect inappropriate behaviors. Pediatric talk therapy is when your child is in the gap between cognitive behavior therapy and play therapy. Next, we have expressive therapy. This uses forms of creative expression such as art, music, and dance to help people explore and transform difficult emotional and medical conditions. Group therapy allows the therapist to observe how your child relates to others in a group setting. Kids that struggle with social anxiety, poor social skills, the group setting offers the therapist a chance to help the kids work through their obstacles with other kids as they occur. And then we have family therapy. Sometimes parents can reinforce kids' anxiety unintentionally. And family therapy can help you recognize this, but also can show ways you can help support your child. What happens if anxiety is left untreated? Some adults assume that children with high anxiety levels will outgrow the problem. Children with untreated anxiety disorder are much more likely to experience anxiety as an adult. They can have trouble in social settings, their jobs, families, careers, and goals, or engage in dangerous activities. Your child can get treatment as an adult, but treatment as a child has more benefits than waiting until adulthood. We know that cognitive therapy, like the ones we went over in the previous slide, can encourage kids to step out of their comfort zone, building up tolerance of their fear. Otherwise, children are more likely to develop poor coping skills, engage in dangerous behaviors, maybe become depressed, or have depressive symptoms. As an adult, they may avoid stressful situations, which can worsen anxiety disorder. So if you have concerns about your child, please talk to their pediatrician. Let them know what's going on, when it started, the symptoms, how often it happens, the duration, for them to help you and your child. Thank you so much for joining us today. The next few slides will show our references that we use for this presentation. We truly hope this information is helpful for you and your family. Thank you.
Thank you.